I'm going to dive straight in because time is precious. IAS president said this morning that we've lost ground over the past 2 years and the most vulnerable have been hit hardest, Dr. Fauci. Just how far off track are we from meeting those 2030 targets?
I think substantially so. And it's unfortunate, but it's just one of the facts of what's happened to us in a global society. We've had difficulty in getting to the global targets. We were making good progress. In fact, I was very encouraged by the number of countries, particularly in sub-Saharan Africa, that were reaching their targets. COVID-19 over the last 2.5 years is a pandemic, as we all know. We don't need to get into the details, of historic proportions, which has disrupted every level of society. From everything from supply chain to accessibility of testing, of monitoring, of surveillance, of treatment, of implementation. So it set back the world in every aspect. The point that I'm going to make in my plenary lecture, and that I made when my comments were at the opening of the UNAIDS in danger report, and that I've spoken about, intermittently with reporters, is that it is absolutely essential that we bring back HIV/AIDS on the global radar screen. That doesn't mean we're going to neglect COVID. We can't. It doesn't mean we're going to neglect monkeypox. We can't. It doesn't mean we're going to neglect all the other diseases, but the need for a coordinated global solidarity, as it were, with HIV has been disrupted, understandably. So we've really got to realize that, and as I said to the press, COVID is going to evolve, and it's going to reach a point where we hope that it is endemic to the point at a low level that does not disrupt the social order. That's for sure. Monkeypox is a challenge, but we will get it under control. AIDS is still with us. It is still the pandemic of our lifetime. We can't, because we've been dealing with it for 40 years, essentially put it kind of in the rear view mirror. It's something we really need to deal with. So I'm very pleased that that is really the core of the conference. Let's get back on track, because it's still a disease, as we know, as you mentioned, Carl, we're slipping in every area. And that's unacceptable.
Yeah, well, Rachel Ong just said earlier at the opening ceremony here that we can find vaccines and cures for disease, but AIDS won't be over until we find a vaccine for equality. And, we certainly know in the United States that there is just this huge disparity. What do we need to do, Dr. Fauci? Why is this still in 2020 in the United States of America do we have this disparity when it comes to healthcare, especially in Black and brown communities?
Well, it is a painful fact that I believe really dates back to the inherent, racism that existed from the time of slavery. And I say that, and it really rankles a lot of people, but it's the truth. If you look at the social determinants of health that do date back directly or indirectly to the horrible aspect of slavery that existed way back in our country from its birth, practically. And that is that if you look at the economic and other issues that people of color, particularly African Americans, face, that they find themselves economically, and with economically also opportunities that they don't have because of that essentially entrenched direct and indirect reflections of racism. So let's look at HIV. So you have, and it's also reflected in COVID, same thing, that you have a situation where you have 13% of the United States population is African American, and over 40%, somewhere around 40 to 45% of the new cases of HIV are in African American, mostly men who have sex with men, mostly young men who have sex with men. And the disparities in health relate to all of the things, the lack of access, the inherent inability of them to get the kind of messaging in communities, particularly in certain areas of the country where inequality in healthcare and inequality in the ability to get the kinds of things that other populations, other demographic groups get, has been there all along. The thing that really was I wouldn't say a wake-up call, but was really a confirmation of the inequities is when we got to COVID. Because when we got to COVID, you have, by the very nature of the situation that brown and black people find themselves in, where they are the ones that are out in the essential jobs in society and have to get out into an environment where there's a very, very active spread of a deadly virus, they, as a population, don't have as easy an opportunity to continue their work and make a livelihood behind the Zoom screen the way a lot of people do. So A, they are more susceptible by risk to COVID. B, if you look at the numbers of once you get an infection with SARS-CoV-2, if you're a brown and a black person, because of the social determinants of health, the lack of an acceptable diet, the lack of good health care, that brown and black people have a higher incidence and prevalence of the diseases that are the underlying diseases that lead to a more severe outcome. And we know what they are: diabetes, hypertension, obesity, chronic lung disease, liver disease, all of the things that were their true equity of health in our society, they would not, in fact, have a higher degree of infection, a higher degree of severity of disease when they do get infected. The only thing about that we need, and I've said this so many times over the last 2.5 years, that we are not going to turn around those social determinants of health and those obstacles to equity in a year or 2 or 3. It's going to be a commitment that's going to be measured in decades for us to do that. And what happens is that whenever we get a challenge, like a health challenge, there are many other challenges that point out and shine a light on inequity. But in my field of health, and whether it's HIV or whether it's monkeypox or whether it's COVID, we've got to remember that when those challenges are taken care of, the inequities still exist. So we need to have corporate memory to know that if we want to not have these inequities exist in the next health challenge, we're going to have to start having literally a decades, if not lifelong, commitment to change it.
Yeah, and then it sort of leads quite nicely into what I want to talk about next, which is the U equals U movement, which you have so wonderfully been such a proponent of really from the beginning. And as the narrative and the messaging starts to shift within the U equals U movement to, U equals U means a win-win, really, for everyone. I'm curious whether you agree with that statement, and if you do, can you expand on how embracing U equals U is a win-win?
Well, U equals U is an overwhelming win. It's, it's a double-barrel shot at controlling HIV/AIDS, and I'll say it explicitly. You know it, but let's say it so that it's here on the record. I mean, obviously, the provision of life-saving medication for the person living with HIV will save that person's life, allow them to be a productive member of society in a life expectancy that when we get even better and better ways of getting people on treatment, by getting treatments that are more user-friendly, long-acting, other types of approaches, that we will have in society a productive group that instead of draining society in the sense of healthcare costs, that they will be actually putting into the economy of society. At the same time, by those individuals having an undetectable viral load, it is one of the most powerful ways to prevent the transmission of infection and keep other people from winding up living with HIV. So it means to me, I've always review in my mind all of the different public health paradigms that have been extremely important in transforming health and specific diseases. So you think about things like public health cleaning up of water.
Right.
Hello.
Hello.
You know, big time. You think of all vaccinations like children's vaccines. And then you think about the scourge of HIV, in which with a medication, you not only prevent the disease in a person living with the virus, but you prevent the virus from spreading to another person. I think when the history of great public health accomplishments are going to be written, I'll guarantee you it may not be universally accepted now, but U equals U is going to be right up there.
Yeah, absolutely. Shifting gears quickly, monkeypox. I've got to ask you because as a gay man living with HIV and seeing some of the, quite frankly, just absurd and ridiculous nonsense that's being politicized out there, you can't help but feel shades of what happened all over again, where we're stigmatizing gay men, men who have sex with men, and the sort of hysteria that I have found within my community is really spreading like wildfire. I mean, people in the gay community, gay men, are really scared. And what are we doing, Dr. Fauci? How do we get a grip on this thing, and how do we stop this? What's the message that the American public need to hear to make sure that we are not calling this a gay man's disease again?
You know, it just, as you well know, Carl, I've been doing this from the first week of the first MMWR report in June of 1981. And we've learned a lot, and I've said it, and I'll say it again for this interview, that right from the get-go, we've got to understand when you're dealing with a public health crisis, the enemy is the virus. The enemy is not the population, be they men who have sex with men, pregnant women, children, adults, the elderly. When a infectious disease finds its way into a demographic group, there has to be an outreach to that group to protect that group with information, with the ability to be open about whatever it is that leads to this spread in the infection. We have four or five pillars now that we look at. First is, unlike HIV, we have a known virus. We've known about it for a while. We have diagnostic tests. Didn't have a lot in the beginning. We have 80,000 a week now. We have vaccines that are effective. We have therapies that were difficult to get because of bureaucratic paperwork and stuff that we're trying to get rid of that as quickly as possible. And then you have outreach to the community. We've got to, and I'm doing this myself, I hope it gets done on a broader way. We've got to bring in the community to figure out with them what is the best way in their community to get this taken care of, to get our arms around it, so that you embrace the community that is most involved. Even though it isn't only exclusively men who have sex with men, right now 99% of the cases are. And we know from experience with HIV, remember, it was almost 100% of the cases back then. And then we found out that it, in different ways, depending upon the circumstances, depending upon where you were, what the societal issues were, that it went beyond men who have sex with men.
But are we calling this, there's confusion. The World Health Organization, I mean, the messaging seems to change every day, and I know these things happen. Are we calling this an STI, Dr. Fauci?
Well, you know, I think in some respects, Carl, it's semantics and confusing.
Yes.
Hello. Both of them. It's semantics and it's confusing, because if you look at what is happening in the evolution of the disease, it is clearly spreading among sexual networks. There's no doubt about that. You can't walk away from that. If you want to address it, you've got to realize what it is. Now, if you look at the sexual networks of people who have close skin-to-skin contact.
Which happens when you have sex, by the way, whether you're straight or gay.
Exactly, that's the point. So you really, I mean, it's a very delicate message that you don't want to say what you are doing with your sex life is a bad thing. You've got to say it is happening in the context of sexual networks. So you've got to not pass judgment on a person's decision about what their orientation and activities are, at the same time that you give them the information that they need to protect themselves.
And are we going to get more vaccines out there? I mean, I personally stood in line for 3 hours and 15 minutes, and that was, you know, nothing in Los Angeles. You know, you've heard it. You know, there are people standing in line for hours upon hours. Where are we at with the vaccine? I know, you know, this sort of caught us off guard, I guess. Were we off guard? Did we kind of get caught with our pants down a bit?
You know, I don't think so, Carl. I think practically it looks that way, but you remember what the history of the stockpiling was not for monkeypox. You know, the stockpiling was for originally after the anthrax attacks. The concern, which was a concern that turned out to be really somewhat distorted, not from Al-Qaeda, a homegrown terror type approach. So we felt if someone was going to get smallpox to be a threat to the entire country, that 100 million doses of ACAM 2000 were produced and stockpiled. In that process, it was says, you know, if you're going to vaccinate the whole population, you're going to need a vaccine that doesn't have the adverse event potential of a live attenuated smallpox vaccine, because people with eczema, people on cancer chemotherapy, people on situations in which they're immunocompromised, we need to make a smaller amount for those people. This had nothing to do with monkeypox. Then along comes monkeypox, and the very population that seems to be overwhelmingly afflicted are a group that are at high risk for immune compromise. And therefore, you find out that the 100 million doses that you have, which we could have just given out to everybody, you know, every gay man who wanted it, the risk of that, we don't want to, I mean, we say we, I mean, the FDA and the CDC doesn't want to give them the risk of having a dissemination of a vaccine that would be more harmful for a disease that's not deadly. So therefore, you turn to Jynneos. But the Jynneos was made as almost a secondary approach for the small group of people who couldn't take the ACAM 2000. And as fate would have it, when this pox virus came out, it came out and afflicted a population who was at a high risk that would not easily be amenable to the 100 million doses, would be more amenable to the safer vaccine, which is the Jynneos. So that's the reason why there was a lot of scrambling to get that part of the stockpile to the people who needed it. Now, what's happened? Well, about 323 or 326 doses have been distributed. There will be another 748 distributed for well over 1.1 million. That's a really much greater improvement than a lot of people online waiting for it right now. However, that means that if we really want to get our arms around this for the community that needs it, we've got to do even better than that. So we've got to pivot away from the more severe adverse event related vaccine, which is the ACAM 2000, to getting much more of the more safe Jynneos. But I think the people need to appreciate that the original stockpiling was not for monkeypox. It was for smallpox.
Last question for you, Dr. Fauci. You've talked about your retirement coming up at the end of the Biden administration. In the Washington Post the other day, there was a quote of you that you'd said back in the early days of HIV/AIDS. You said, if ever there was a disease that was made for me, it was this new disease. That was back then. Do you still feel that way, and why?
Well, I was trained and have been trained in internal medicine, infectious diseases, and clinical immunology. So when HIV came along in 1981, I had already had a considerable experience. I finished my medical training in New York City as chief resident of medicine, and I took a fellowship in infectious disease and immunology. And from 1972 to 1981, I was bridging that world of immunology and infectious diseases. And then along comes a disease that's an infectious disease that afflicts the immune system. And that's what I meant. If there ever was a disease for which I was trained for, it was HIV. And that's what I meant by that statement.
What does retirement look like for Dr. Fauci? Have you started thinking about it? Are you fantasizing about it?
Right now I'm really busy, but the thing that was mistaken about that announcement, as it were, I said I don't see myself in the federal government beyond the first term of President Biden. That doesn't mean I'm going to stay till the end of the first term of President Biden. It means somewhere between now and the end of the first term, I will think not of retiring, but getting out of government service and using the rest of the years that I have and the energy and the passion I have to continue what I do in the field of global health, including HIV/AIDS, including COVID, but to do it in a different venue while I still have the energy and the passion to do it. Well, but I haven't decided when that's going to be, Carl.
Well, I've said it to you before and I'll say it again. I truly believe you are the definition of a true American hero, Dr. Fauci. So thank you personally for everything you've done, and not just for people like myself, but all over the world. Thank you so much, and thank you for giving me your time today.
Carl, anytime. I appreciate it. Thanks. Always good to be with you.
Thank you, sir. Have a good one.